colleagues. So the era between 2005 and 2010 saw a medical boom in India. A chain of hospitals mushroomed. Medical tourism got a boost. With regards to spine surgery, MIS became a buzzword. So much so that Times of India covered a center page on how a sextant works. So even sextant became a household name, and homemaker knew what a sextant, how the sextant works. So two things: one is MIS, and the second thing is disc replacement made its way into our lives. So in this wave of media's hunger, we also sailed. So we did the first ProDisc L in India. We did the first ProDisc C in Bombay. We did the first two-level the Medtronic's metallic disc, lumbar disc then, and the first ProDisc C, as I said, in Bombay. So there's a lot of enthusiasm. And doing something new, which we were not taught during our MS, created an excitement. So this was a lady where we did a disc replacement C5-6. I'm sure this can be managed endoscopically. So this excitement continued. So all these discs moved. Another patient with a ProDisc, again moved another patient with two-level ProDisc, moving very well. Another patient with a Prestige, moving. You can see the seesaw movement there, inflection extension. Then they stop moving. So they come with the follow-up gives depression. So they stop moving over a period of time. Not only do they stop moving, they fuse, and they also cause ASD. So as your follow-up increases, this is what you stand to observe, and the reason being heterotopic ossification and subsidence. So heterotopic ossification is something which we desist. So it beats the very purpose of what we do. Its incidence increases with the duration of follow-up. It can extend up to 65%. Some papers even say 70 to 80%. It's basically an expensive fusion. So we need to have a better understanding of this. Again, subsidence, I usually don't curate the bony end plate. I'll show you what attempts we make to prevent this kind of an issue. So we make all sincere efforts to prevent these things happening. In spite of that, we get this kind of fusion after some years. So to prevent heterotopic ossification, I don't use a monopolar in AS when I do a artificial disc replacement. Monopolar is thrown away. It's all a play of bipolars. The elevation of longus coeli is all with the bipolar. It's very, very delicate. There's no bony work. If a patient needs an osteophyte to be removed, I usually don't do a disc replacement, because I know anything that incites bone formation is going to cause osteophytosis. At every step, there is a liberal saline wash given. Every bony raw surface is plugged. This is done very, very meticulously. I don't give indomethacin, but there are papers which advocate indomethacin advocacy. Again, to prevent subsidence, you have to select your patients well. It has to be a young patient with a soft disc, with a tall disc height. Remove only the cartilaginous end plate. Keep the bony end plate intact. The choice of implant should be such that you don't put the implant in distraction. Put it in your natural mode. Put the widest footprint to prevent disc of widest footprint at the shortest height to prevent subsidence, because it occupies the cortical rim. And if the patient is really osteoporotic, actually you don't do a disc replacement. And this is what has been advised. We went to the extent of actually matching the discs that are available in the market with the anthropometry of Indian population to prevent any kinds of subsidence. And this is well published. So these are my indications: soft disc herniation, tall disc, younger patient. It could be chronologically young patient, deformity, elderly, age group, narrow disc space. It's pointless doing a disc replacement in such a patient. So ideally it would be a patient with a soft disc like this. This is a rocky mountain. It's stupid to do a disc replacement in such a patient. Another rocky mountain, kyphosis, reduced disc height, osteophytosis. Not a good patient. This patient is going to fuse ultimately in some time. Another patient with soft disc. Another patient with a young patient with a soft disc herniation causing myelopathy. which needed no major bony work. This is something where you will desist from doing a disc replacement. It's far, far away from disc replacement. You cannot correct deformity with disc replacement. This is another good indication. Soft disc to adjacent levels. So if you think of it with long-term follow-up, it is defeat all over the place. It's studied with defeat, including the indication itself. In comparison to ACDF, there's only one indication where you can do a disc replacement. Even in that particular indication, there are sub-indications where it deserves a mention. I feel the very rationale of doing a disc replacement to prevent ASD is misplaced. It was presumed to be a result of transfer of stress, but there is enough literature currently to advocate that it is basically a natural history of the adjacent level and malalignment of previous surgery that causes ASD. I'll just summarize these interesting facts, which are again underlined by the last bullet point, industry driven. So neurological success, yes. Kinematics, yes. ASD, yes, better than ACDF, but marginal. Heterotopic ossification is more common in constrained discs. Unconstrained discs, you might say, to put an unconstrained disc, but these are prone for displacement, kyphosis, execution. There are execution limitations. If you remove PLL all the way and put a mobile disc, unconstrained disc, it's going to displace. It's going to displace posteriorly. Again, heterotopic ossification. But there is still triumph. Yesterday our guest spoke about Abdul Kalam Azad failing 101 times when they were making the rocket. So similarly, the triumph is there in our thought. So we don't want our, to create a population of ankylosing spondylitis, fusing each and every level. So the thought that our discs are made to move, that itself is a big indication. So we have taken the first step of doing this first generation discs. We need to analyze the problems, look at the challenges and work on them. The human mind is too strong, and I think we can surely come out with newer models, newer implants which really move. Thank you.